consultation for the Children's Assessment Unit at Bassetlaw Hospital. So across to DBH colleagues.
Morning. Tim should be joining. So, Aline, did you want to just give an update on the consultation in terms of the feedback?
Yes, and sorry to sound as if we're passing from pillar to post, but actually it's going to be my colleague Rachel that's going to do a quick presentation on the findings that we found from the consultation on children's urgent and emergency care. So she should be able to share her screen shortly.
Okay, hopefully everybody can see that now. Okay, yeah, so just a very quick kind of update on the consultation findings really, and where we are. I won't dwell too much on the case for change, obviously, because I think you've obviously discussed that before and you're familiar with that, but just in brief, obviously the funding of 17.6 million was agreed and announced that would allow the creation of an emergency village at Bassetlaw Hospital, which kind of supports that ambition of bringing high quality services kind of as close to home as possible. But that also meant that there was the opportunity for the CCG and DBTH to look at what the future of children's and urgent and emergency care looks like in the future, and address some of those kind of challenges that resulted in the temporary changes that were brought in 2017. So with that in mind, the CCG wanted to consult with patients, staff, partners, the wider community, anybody that could potentially be impacted and might have an interest in using that service to inform the decisions moving forward. So the main issues that were being looked at through the consultation were we asked about people's experience of urgent and emergency care recently, just to get an idea of what people thought about the service as it exists at the moment. And then we specifically asked about what would be important to people in the new Bassetlaw Emergency Village in the creation of that, so helping to look at the design and the different features that people would like to see. And then obviously we asked about the people's attitudes to the different options that were put forward for those services in the future. The consultation started on the 7th of December last year, and it closed at the end of February, on the 28th of February. So in terms of the process itself, it was both the CCG and the Trust kind of had a really good comms activity throughout. So there was obviously information on both of the websites, a kind of regular press releases and social media. And we also really pushed the information out through partner organisation channels. So it was appearing obviously in other newsletters and venues, and we had posters to publicise publicise engaging in the consultation, if you like. And there were a number of ways in which people could then give their feedback to the consultation and have it recorded as a response. The main vehicle that was set up was the online survey, but that was also available in paper format, and we did translate that into Polish as well to help with engagement with Eastern European communities. There was a range of meetings and engagement drop-ins that were everywhere from kind of supermarkets to visiting the Children's Assessment Unit itself. And then looking at who we really wanted to make sure that we heard their views, or their views were heard through the consultation. We also particularly targeted parents and carers children and young people through kind of schools, youth groups, and a children's competition was also set up with the Trust. And then kind of outreach work with rural and Eastern European communities as well. As I said earlier, the social media presence was really strong throughout, and we encouraged submissions both from individuals and organisations, just in the form of letters, emails and telephone calls as well, if people didn't want to complete the survey. So in terms of what that response looks like now, which is the kind of the end point, if you like, we had almost 2,000 responses to the consultation. As you'll see, the majority of those have come from the survey, and I think that's just because it was the main vehicle that was publicised throughout. But each of the different mechanisms that we had in place did receive responses. So everything from the little feedback cards where people could just write whatever they wanted, through to emails and people taking part in conversations with us when we were out and about in the community as well. And we've also looked at what people were saying in response to the social media posts on the Trust and the CCG social media posts. So the final figure is 1,983 people taking part in the consultation across those different forms. We can see, I don't know how the writing might be a little bit small on this, but I think one of the great things is that 70% of the individuals who taken part have got experience of using urgent or emergency care at Bassetlaw Hospital. And obviously, consultations attract those who are most interested in the changes that are taking place. But it's good that we know that we've reached people who not only have used it for themselves, but then 64% of people said that they'd accompanied a child or young person to use that service as well. And on top of that, I think the kind of stakeholder communications that were sent out through partner organisations have clearly worked, because we've got around 20% of the response from health or care professionals in other services and working in urgent and emergency care at Bassetlaw Hospital as well. We've got representation there. The list of the organisations down the side is just a list of people who, organisations and elected members who have submitted responses to the consultation as well alongside that. So what they said, the interesting bit, in terms of actually what I haven't got on here, but one of the things I should say is that in terms of those 70% of people who've got experience of using urgent and emergency care, 85% of those said that they were satisfied with the service that they'd received. So and that kind of message about the people being largely happy with the service that they've received recently came across in all the different consultation methods and responses that we used. But what people said about what they wanted from the emergency village and the kind of factors that would be most important, probably no surprise that the top there is the timely access to clinical assessment. And then the second, the staff being available to help with queries and information. And then thirdly, the environment. And I won't go through them all, but you can see there, and that was quite a consistent picture through both the survey and the conversations that we had with people. And when people were able to kind of elaborate on that, one of the things that came out clearly and consistently was that need to kind of make sure that actually it was the facilities were welcoming for children and families. So in terms of the space and the privacy and separation from the kind of adult areas came across quite strongly in what people were saying in their qualitative responses. And in some of the conversations that we had with organisations, the role of volunteers and also the resources for kind of play and things like that came out quite strongly as well. And then, so the options for the future of the children's urgent and emergency services, the three that were kind of explained in detail to people in the consultation document was obviously number one, continuing the current temporary model where the children's assessment unit stays where it is, but it closes at 9 p.m. each evening and patients are transferred to DRI from 4 p.m. Option two was to build a new children's assessment unit next to the emergency village, or what will be the emergency village, but to continue closing that at 9 o'clock and for patients to be transferred to DRI from 4. Or the third option was to build the new children's assessment unit and also introduce the idea that children could stay at Bassett Law Hospital for a short stay, which would include overnight, but patients requiring a longer length of stay would be still transferred to DRI. We also did ask if people had alternative options that they thought that they should be considered moving forward. So without going into kind of too much the detail of what people said about each of those in this here kind of today, it basically 88% of people opposed option 1, which was continuing with the temporary model, 82% opposed option 2, and then 84% of people supported option 3. And this, we then asked, so each of the options were asked in turn about the level of support from kind of strongly support to strongly oppose. And then there was a subsequent question, which was your preferred option. And that's the response that we're showing on the slide, is that 85% of people, their preferred option is option 3. I think what's interesting is when you unpick the reasons for that a little bit, which is obviously what we'll concentrate on in the report as well. But generally, people really felt very strongly about having that access to care locally 24/7 and being able to stay overnight. There was the amount of people we spoke to who had done that journey to Doncaster quite often in the night, and the impact of that really kind of came through in the patient experience stories that we heard in the consultation, and where I've kind of said negative impact of travelling further here, but to unpick that a little bit, it's not just the trauma of the journey and the fact that it's a longer journey, it's then that you're further away from the support that you might have at home from other family members, or just being able to pop back and get a change of clothes or that kind of thing, but also the discharge process, because obviously some people might be taken there in an ambulance but then might have to find their own way home, and we heard lots of kind of stories about the impact of that as well, and also being able to see their other children, and a general recognition that actually, children generally, thankfully, don't need to stay in hospital for a long time. It is that kind of crucial 24 hours where people just need that reassurance that they'd be able to be seen in Bassett Law and then hopefully be able to return home. And the third point up there was that kind of continuity of care and the familiarity of just being somewhere that travelling somewhere that and a lot of people mentioned the impact on those who obviously don't have their own transport or who would struggle to get further afield as well. In terms of the reasons, kind of or some of the qualifying reasons against option 3, there was quite a few. There were obviously, this is in the context of 85% of people preferring option 3, but quite a few people said did show some level of support for option 1 or 2, because they felt that it made a better use of the limited resources that were available. And that there was something about having that kind of consistency of service rather than kind of overstretching the resources. And I think that's possibly reflected a little bit in some of the organisational responses that we've seen as well, just making sure that moving forward, things like staffing and the challenges that you faced previously are addressed to ensure that that continuity and that consistency of and deliverability of the service into the future. But the main kind of point in against option 3, if you like, is that people were pushing for even more services to return to Bassetlaw, and they didn't feel like it went far enough at this stage. So in terms of the consultation findings, that's kind of it from me. But just to say about next steps, obviously at the moment we're finalising the report, and that will be made available and shared with you in the next couple of days. And then we've got Health Scrutiny Committee on the 29th of March, and then the full kind of decision-making paper will come back to the next governing body in April. Sorry if anybody has, I don't know if anybody has any questions at that point.
Thanks, Rachel. We'll open it up to questions, but I'll start off first with a couple of quick questions. One about the money. 17.6 million was promised quite a few years ago, and 17.6 million doesn't buy as much now as it once did. So are we looking at an emergency village or an emergency hamlet? And key for a lot of these things is workforce.
So in terms of the kind of what 17.6 million will buy us, Eric, it obviously doesn't buy us as much, and so there's quite a lot of work going on kind of with the ICS across South Yorkshire and NHS England in terms of what. So in terms of that, we're talking in terms of inflation about 1.8 million on top of that. So we have a scheme which fits into that envelope. It's not the ideal scheme, but we have a scheme that will give us an emergency village at the front door with the co-location, which makes it achievable and sorts the efficiencies out. So the workforce bit is obviously from a medical staff. We've never changed the medical model. So the medical model will remain the same as when we had an overnight ward. Now the medical model will get better because we're separating the SHO rota in terms of having an SHO separate, because 75% of the time we had one across obstetrics and paediatrics. Well, that's now going to be, for a pilot period, we'll have separate ones. So the ODN are aware of that, and specialised commissioning in terms of SCABU. So it's nursing workforce was the big issue. Since we closed, we also have had obviously the Royal College of Paediatrics and Child Health saying that we have to have 2 registered nurses in ED for a children's ED. So actually, in terms of our current establishment, we only need 3.26 additional staff to staff it. So part of that is looking at the workforce model we have. So we haven't had any TNAs or nurse associates within paediatrics. We're just about to have our first 3, and that's part of the process for Bassetlaw in terms of that skill mix and change. And we also have our first 5 overseas paediatric nurses being interviewed this week. So in theory, we'll have all the gaps completely filled. And obviously we've got 2 years now because obviously the building won't open until 2024. So from that perspective, it looks a bit more promising from a workforce perspective than it has done previously. We'll have to see how the overseas recruits go, because obviously they are very experienced adult nurses who are really experienced in paediatrics. So the OSCE centres is quite specific, and we'll put them directly onto the children's register for the NMC. And we're going to have to see then how that affects other adult nurses who currently work in paediatrics who can't get promotion, whereas these people can. So there's some work I'm doing with SHU around a conversion course from adults to peds, which will be quite short. So there are lots of things that we've got in train to allow that workforce to and we'll explain that to every scrutiny. And the other bit just to say is that we are due on the 22nd of March. The Senate review will come back for its final version, which again supports option 3. But then just some of that without workforce. But we are looking at all the other elements of workforce that were in that review in terms of working much more closely with primary care, in terms of the nursing services. So that work started already.
That's excellent. Thanks, David. Tim, you want to come in?
Yeah, thank you, Eric, and thank you, Rachel. It's quite a rare opportunity to get this level of patient feedback, this direct feedback. And it is very specific, as you've said, Rachel, that these are largely people who have had children that have accompanied to our services. And I can see there's overwhelming desire for timely clinical assessment, obviously, and option 3 is the standout one. But it's interesting what else is important, isn't it? Signage, surroundings, and so Wi-Fi. Obviously, that's the world we're in. And I just wonder how much of that we can take forward into other parts of our organisation, because I know signage is an issue because I'm always directing traffic in the corridors at DRI. It's very complicated. And I think given that there will be a time scale for us to get to the emergency village in fully functioning fashion, I just wonder what else we can do on the way, because the issue of being transferred to DRI and it being a long way back to get a new pair of pajamas for your child and a long way for your other child to pop in and see their sibling, the distance is always going to be hard. But I do wonder if there's more we can do to help with some of that, because there's going to be a period of time where we continue to transfer larger numbers than we will to DRI. It's just something for us to ponder as an organisation, I think, with partners.
Thanks, Tim. And yes, it's been an excellent consultation, and it's great seeing virtually 2,000 responses over a relatively short
very good
period of time. So actually, well done there. Have we got any other questions or comments, Idris?
Yeah, just a couple of observations. Really, I'm picking up that point, Eric, that you've just made. The consultation, the report on it, I think is excellent. It's in the context of actually it was when the Omicron wave hit us and we can't do face-to-face and things, but we've got approaching 2,000 sort of responses. But also what I think is really positive about it is we've got, I think, across quite a complex message, because what we're trying to put forward, and this is both commissioner and provider, is that we can have a new model of care that will support paediatrics better. It's not a ward, and the most acutely ill children will still be transferred to either Doncaster or Sheffield. But also, that was always the case, wasn't it? That's not a fundamental change to the pathway of care from what we had historically. But it's not a ward, and usually, getting across a message to the public of, well, it's either a ward or it's not a ward, so which is it? Have we got a service? Have we got paediatrics overnight or not? And I think people have shown a really good understanding, because even those that have said, well, the options that you put forward, we agree with this option, there's a lot of consensus. And those that have said, but we'd like more, they're still recognising that this is a significant improvement from what we've got, and they can see the pragmatism behind it. And in terms of that pragmatism, I'm really pleased that we have a relatively small district hospital in Bassetlaw. I know the public have feared for its future about A&E and other services in the past. And clearly services have had to be adjusted over the years. I mean, since I've been the chief officer, we've seen a number of changes. Some bring more services into Bassetlaw, and I would like to see that continuing as well, particularly around some elective work and things. But what we've now got, I think, is a hospital model for a small district hospital that means you can have very comprehensive range of services around urgent care, around paediatrics and other services that can deal with the vast majority of presentations from the public, both sort of electively and acutely, but to do it in a sustainable way, in a way that it means that we can use staff most effectively, that we're not spreading people too thinly, and that we can use the resources that we've got, you know, in the most efficient way. And I think we've reached that very rare sort of pivot point of excellent local services without actually having the benefit of a large district or a specialist, you know, sort of large hospital. So I think it's to be commended, but I think also the public seem to have grasped this and what this is about, which is really positive.
Thanks, Idris. I think you summed it up nicely there. Any other questions or comments for our colleagues from DBH? No. Well, Rachel, Aline, Tim, David, thank you very much for coming and sharing the results of the consultation with you. As ever, the CCG, whilst it's here, and the Bassetlaw Place-Based Partnership going forward, will be working collaboratively with you to actually ensure what we all want, the best outcomes for our population.
Excellent. Thank you very much.
Thanks a lot. See you later.
Bye, everyone.
Thanks.
Right, so back to our agenda. That was a great consultation. It's not often we give the credit that DBH deserve, but that was a great consultation. Great results. Getting back to the agenda, we've got apologies from Louise, from Sue, and I believe from DT as well. Everyone else looks like they're here, so I can confirm that we are quorate. Any additions to the declarations of interest? No. And Victoria, any questions from members of the public? I haven't been informed of any, so it's shaking his head, so take that as a no consultation. So moving on, it's minutes of sorry, it's slow at scrolling down. So minutes of our governing body on the 18th of January, page 1, 2, 3, 4, 5, 6, 7, and 8. Are we all happy? Hession, any issues you've noticed? Well, Hession's happy, so that's all good. And then our shorter governing body on the 15th of February, 1, 2, and 3. All happy, good. And then we've got 2 outstanding actions for Victoria around performance. First, overall sort of waiting lists increasing and the effect on primary care. Obviously, it's been picked up at the place-based, the Bassetlaw Provider Collaborative, and there's about communication updates to patients. That was raised with DBH, Victoria?
Yeah, that's been raised on a few occasions now, Eric. So the action is completed. Just to say that there is obviously now the national website and resource available through NHS Digital, I believe, which is the My Planned Care website. And that in itself should now be the go-to place for all patients and members of the public to understand the comparative waiting times across a range of different specialties. Although I do think it's worth noting that it's still very embryonic in its development and it needs a lot more information to be put in there. DBTH and indeed other acutes across the system have agreed to do so and will be participating in that. But it is going to take some time and resources to get the level of detail that I think would be really, really helpful for patients. But that information is available, Eric.
Yes. Hession, have you been on the website?
I suppose that was my question, is how much detail is on the website currently, and is it
very little?
very little?
Yeah,
And
so it's
how
got the
long?
different specialties, Hesh, and you can click on the different specialties and then it'll come up with, so for example, orthopedics, it just tells you there's a 43-week wait at the moment for DBTH. You can go on to, you go into a region and then you go into the acutes in each of those regions and then you go into specialty level data. So it just gives you a general overall level of weeks expected to wait.
Okay.
What we're anticipating is that as that site matures, there'll be a lot more information on how people keep themselves fit and healthy and well, and also support their own care and self-management from those particular specialties for each of the acutes, with obviously an expectation that that advice and guidance will be fairly consistent across the ICS footprints.
Okay, thank you.
Thanks, Victoria. And the next action was on the sarcoma pathway, which again has been fed through the Basel Provider Collaborative. I think we're just about there.
I think we're just about there. I missed last week's meeting, but yes, we've got a position where that sarcoma pathway is now in place and it is known, but we're still working through with colleagues to make sure that there's absolutely clarity around other access pathways for non-obs ultrasound. So yeah, I think we're about there. The action itself has been completed, but I still think a bit of work to go to make sure that we've got all the appropriate guidance in place to support effective referral management.
Thank you, Victoria. No other matters arising, I believe. So I will move on to my report, which sort of touches on what I sort of alluded to initially. This was meant to be our last governing body. We were ICBs were meant to be up and running from the 1st of April. That has been put back until the 1st of July. I've had no further updates. I'm sure Idris will update later on the transition. So our governing body will be carrying on for the next 3 months. Sadly, it will be carrying on without the legend that is Hession. This is his last governing body. Hession, how many hundreds of governing bodies have you been to?
Many over the years.
Yes.
I suppose I just wanted to say thank you, really. It's been truly humbling to get such positive feedback from all of you, really, every single one. I think it has been an absolute privilege to serve the population of Bassetlaw and to be part of so many clinical pathways over the years, and to be part of such a great team. And I've learnt a lot from each and every one of you, and for that I'm eternally grateful. I suppose someone asked me, you know, are you leaving behind a legacy? And I thought, oh, I've never really thought about that, but I hope my legacy would be the strong friendships and the relationships I've built with all of you and other stakeholders, and I hope that will endure far into the future, beyond my kind of formal tenure at the CCG, and who knows, you know, my heart is with service development, so at some point in the future, I suspect when the timing is right, I'd been back. So no, thank you again. It's been an absolute privilege. Thank you.
No, thank you, Hession. It's been a privilege for me and everyone else to actually work closely with you. You'll be missed, but I know that you'll be back, and I look forward to that day. I said COVID seems to have gone quiet, but COVID seems to have risen its head again. Numbers seem to be increasing again locally. I know at Riverside yesterday, half our reception team have suddenly come down with COVID. So it seems to be a re-emergence. I don't know if other practices have noticed the same, Hession?
Yeah, I think it's happening regionally, nationally, etc. I've heard of certain schools now in Nottinghamshire who've sent entire year groups home to work remotely from home because of the numbers. That's kind of expanding, if you like. I suppose for us, it's it's about safeguarding our workforce. All we can do is safeguard our workforce within the work environment. We can't really influence how they behave outside. But this goes back to my point which I raised at Bassetlaw Provider Collaborative, really. Is how do we safely look after patients who might have respiratory symptoms within the community? Because at the moment, for the vast majority of us, we don't really have that ability to segment the patients into different areas when they require assessments. So the fact that we are all now seeing face to face, we're bringing people in, etc. I think there is a risk. Thankfully, it's not translating into hospital admissions to the same extent. Even though the numbers have gone up, certainly the ITU numbers haven't significantly increased, as far as I'm aware, nationally. So that's a positive. But in terms of actual impact in relation to workforce being absent from work, because the IPC rules still apply fully to health in terms of isolation, it is a challenge. So I think I'm not quite sure what the solution is. As long as the weather's all right, I'll probably be bringing patients into the car park and assessing them there rather than bring them here. But if it's wet and raining, etc., I'm going to struggle. So I'm not quite sure what the solution is really going forward, at least for the next few months. Thank you.
No, thanks, Heshen. Again, our PCNs will be ramping up the vaccination programs from April for our over 75 and our care home residents. I believe we've done over 250,000 vaccines so far. So well done to our PCN teams and local community pharmacists as well. And the other big issue is Ukraine and the terrible situation there. That's only 2-3 hours away. It's dreadful. A number of us I've got colleagues with links to Ukraine. I'm thinking Heshen, especially of Dan. So actually, it's something that does actually touch us closely in Bassetlaw. I know at Riverside we've started a collection a couple of weeks ago, and we're doing what we can to support. And I'm sure health colleagues, both across the CCG but also across the wider partnership, are providing support. Victoria.
Yeah, just to fully support that, Eric, it's an absolutely deplorable situation that's happening in Ukraine at the moment. It's very concerning for everybody from a colleague and staff perspective, but also from a patient perspective as well. People having immeasurable harm done to them as a result of the war that is happening in Ukraine. Just from a Bassetlaw Place perspective, obviously we will need to amend the agenda to make sure that is a really important issue that we discuss across our place partners about what we do to support Ukraine residents coming into Bassetlaw. I'm not sure what our response as a Bassetlaw Place has been on this agenda yet. So I look forward to picking that up. But also from an NHS perspective, again, I'm not clear on the arrangements that are being put into place to support anybody that does come into or is housed by Bassetlaw households, about the wraparound services, both from a health and an education and a general welfare perspective, because obviously there are going to be multiple needs that we're going to need to respond to. So I'm just curious about what our overall place response is going to be to this very, very emerging tragic set of circumstances. So I'll pick some of that up, but definitely needs to be on the place agenda the next meeting.
Yeah. Thanks, Victoria. Heshen.
Thank you. Yeah, in terms of the NHS response, there has been a very, I say, draft migrant health guide that's been produced by NHS England around how do we cater for Ukrainian citizens who might be leaving and coming to the UK. There aren't any surprises in there. The focus is very much around infectious diseases, malnutrition and mental health. And you're right, Victoria, I think what we ought to do is bring this as part of a provider collaborative conversation to see what each provider could contribute to that kind of overall kind of framework and expand on it. So again, health aside, I mean, the other thing is social care, isn't it, in terms of housing and support, etc. So that wasn't really mentioned within that migrant health guide, but the provider collaborative may have other ideas in terms of how that can be supported. So that's a starting point. Thank you.
Thanks, Heshen. Thank you. Idris?
Thanks, Eric. I just want to start with a personal reflection about Heshen. You're going to get a lot of this, aren't you, Hesh? I was thinking back to when I started in the CCG as the chief officer, and Heshen was on the executive at that time. Heshen's the only other executive member that's been an executive member since I began. So thanks for bearing with me, Heshen, sort of throughout. But my overriding impression of Heshen when I first started was he fitted the aspiration that I had for any organisation that I wished to work in. Yeah, in terms of the professionalism, the dedication, the hard work, the attention to detail, but seeing the big picture. But probably most importantly of all, how you relate to other people, and the respect that you show to people, and that way of working. So yeah, I just want to give a personal thanks, Heshen. You know, it feels like you've been part of the sort of that core team from the outset of me starting, and I can't tell you how valuable and grateful, you know, sort of that has been. So thank you. In terms of picking up the other issue that we were just talking about Ukraine, this impacts on us all, doesn't it, in terms of conflict in, you know, sort of a European democratic nation, and what that actually means, you know, sort of for peace and democracy in Europe. And like you say, Eric, you know, it's a short distance, isn't it? You know, it's almost on our doorstep. I know that nationally they are starting to build up the response that we can provide from a health service perspective, and in particular to support those refugees. And I would personally like to see the country take far more refugees, and hopefully the schemes that are being put in place will work effectively. And I think we need, as a health and social care system, to stand alongside that to support particularly those families that will be taking in refugees to their own homes and the support that they will require. So there'll be a lot more sort of on that in the coming days and weeks. It has other implications for us as well. From a health service perspective, I think it's fair to say that we got a reasonable allocation from the Treasury a short time ago. That looks really positive from a healthcare point of view in terms of the recovery from COVID. But inflation and fuel prices and the impacts of this, you know, it is a wave of cost and challenge, you know, that is hitting us that will make that more difficult. So I think, you know, so the whole nation needs to reflect and understand on how we can support Ukraine, but also recognising the challenges that this will bring to the economy and the public sector for us all. And that patience, understanding and support, I think, will be really important, because it is, in my mind, part of our response to standing alongside and in support of the Ukrainian people. A number of the other items that I've got in my briefing, I will be covering later on in the agenda, so I won't cover them in detail now. But last month, we formally ratified Stuart's appointment as our interim Chief Finance Officer. Since that time, I'd like to congratulate Stuart on becoming the Director of Finance Designate for the Nottingham and Nottinghamshire Integrated Care Board. A fine appointment, I feel, but also it's great news for us because it gives us real continuity. And I know Stuart and his team have already become involved in the detail and the work, both from a planning point of view, but really getting to understand and support sort of the basketball place. And I'm very grateful to Stuart and his team for really stepping up to the plate on that. It's been quite impressive and very encouraging. And of course, a number of other appointments have been made to the ICB board, both in Nottinghamshire and in South Yorkshire. I'll go through that when we get to that agenda item. as I will for the integrated care system. But just at this point to note that we continue to progress that. I think it's progressing well, and I'll provide more details sort of later. And on Omicron and boosters, I've got an agenda item again later on about vaccines and COVID and flu, so I will go into some more detail then. But I'll just pick up the 500,000 doses sort of headline. Yeah, 500,000 doses of vaccine to Bassetlaw residents in what has been a relatively short period of time, and a significant proportion since the meteoric or catastrophic almost rise of Omicron, where by far the best response to the Omicron variant was to get the booster out. And what a fantastic sort of results we've had in that regard. And we've got some of the highest levels of vaccination rates in the country. So it is a very impressive response, and that shows itself, I think, in the reduction of serious illness, not necessarily the numbers of people who have COVID, but the numbers who are contracting serious illness as a result. And I'll go into more detail on those items later on in the meeting. Thanks.
Thank you. I think it's 250,000, not 500,000.
I'm boosting us more, do you think?
But yes, thank you. Nicola, quality and patient safety update.
Yes, so few key headlines really. So the care homes and home care market are still seeing some impact from COVID, although the outbreaks have reduced significantly over the last month, but we are still seeing pockets of staff that are still presenting with positive testing. So Sally and the team are continuing to work really hard to support them. And on a positive note, Sally's team have now got Jane, that's moved over from finance, and Steph, who's on secondment from DBTH. So we have got a slightly bigger infection prevention and control team now. So that's really helpful. The care home audit programme has been challenging, and I think we were on track to complete the whole programme, and then Omicron arrived. So we've been through it earlier last week and risk assessed a couple of the providers that we will visit April next in the new year, rather than trying to get them visited now and struggling. They're low risk providers, so that's been really good. Learning disabilities, we continue to do all the reviews that we're required to do, so visiting quite a lot of our inpatients over the every 8 weeks. We have had a couple of people discharged from the Orion unit, so obviously our inpatient trajectory it's not quite halved, but we're getting there. So that's really positive. And we've got discharge dates for 2 other individuals over the next couple of months. So after a lot of hard work, we're now getting people back into the community and into settings that can support their needs. And we've also completed all the safe and well checks that were required on the back of the Norfolk safeguarding report. So we've visited all our people, and they're going through the panels in Nottinghamshire shortly. So we've completed that work. From a personal health budget perspective, we continue to offer personal health budgets across Bassetlaw, and there's a mixture of people that have personal health budgets and different services, so that's really positive. And I suppose it would be right at this point to thank Hesh for all his support around personal health budgets, and he's now passing the baton to Eric. So Eric's going to be signing off the personal health budgets with myself going forward. Continuing healthcare seems to be going very well, and we still are struggling at times to get packages in the more rural aspects of Bassetlaw, but we work through that with providers and also with the trust and Notts Healthcare Trust when they are making requests for home care. And we've been doing quite a bit of work with our colleagues in Nottinghamshire, looking at areas of quality that we can start to align going forward. So we're working with them on a prevention of future death process, so they haven't got a process either, so that's really very timely, and we just need to work with our Doncaster colleagues around how we will understand anything that comes through the trust, obviously post the 1st of July. But it's a real opportunity to do something that that will be of benefit to all organisations. We're also looking at how we can start to align complaints into Nottinghamshire. So I've had some very early conversations, and we've agreed as of the 1st of April that all our complaints will just be logged into the Nottinghamshire system. We'll continue to manage them and have the oversight, but so that going forward we'll have a full year of data for the ICB at the end of that financial year. So again, something really positive. The patient safety specialist agenda, Nottinghamshire have a well-structured group with their providers. So I joined the meeting very recently, and again from the 1st of April we're going to work very closely with our colleagues in Nottinghamshire around the patient safety agenda. And we're also liaising with the acute trust, so Doncaster and Bassetlaw hospitals, how they align into that as well, because obviously whilst they'll be staying in South Yorkshire, we'll need some assurance around what they're doing in relation to patient safety. And finally, myself and Eric are quite well linked in with the quality meetings, the clinical quality meetings on a Friday morning, and a piece of work that's been developed out of that, led by the Rosa and the quality team, as a draft quality strategy. So which is one of the requirements of the ICB. So that's we're going to meet a publisher today to do some fancy work around the strategy to make it look interesting and inviting to the world, and again we can adopt that going forward. And be part of that. So I think there's some real opportunities around quality. We're taking it slowly, we're working closely with them, and where it makes sense to do things now, we're doing it. Where it doesn't make sense, we're waiting and holding on. And we've in discussion with Andrew, we're going to use the Nottinghamshire quality schedules this year. So we do have a lot of very common providers, so we've agreed we'll just use the quality schedules that they've put together. It saves us doing a piece of work, and then for DBTH we'll work through this year with them around what the quality schedule will look like from 2023. So we're not going to do anything different with DBTH for this year. So it's just if there's any questions about any of that.
Thanks, Nicola, for that comprehensive update. Do we have any questions? No. Thank you. Well, sticking with you, Nicola, to approve NOT's looked after children and carers leave strategy.
Yeah, so this has been produced with all our with all our partners, and obviously we've signed up to this, so it's just to note and approve it. I've already given them my signature to add to it already, so we just wanted to bring it formally through governing body to know that the strategy is in place. And obviously Kathy leads on this work for us, and is very well linked into Nottinghamshire and also linked into South Yorkshire where it's appropriate.
That's great. I think we're all happy to approve it. Thanks, Nicola. Stuart, financial report month 10 and then financial plan.
You're on mute, Stuart.
You're on mute, Stuart.
You're on mute.
If I could firstly draw your attention to pages 41 to 48 of the pack, looking at the financial report to the end of January. I suppose in summary terms, it's a, and I'm sure you've been understanding this as you've gone through the last 2 years. We're in the middle of an emergency financial regime, which has changed the way in which the CCG's finances are managed significantly, particularly in terms of block arrangements with providers. And what that is showing at the moment is that we have a surplus at this point in the year, and we are anticipating a £2 million surplus at the end of the year. It is important to recognise that these are, as I say, emergency times, and although that showing that surplus in year, what I've yet to do and want to do is to get behind the recurrent underlying position behind that. And as we've been doing the plans for next year, that's starting to emerge and to highlight some challenges for us. So at the moment, we've got a forecast £2 million surplus. Normally you would be talking about the sorts of significant risks to that at this stage of the year, and it's probably as much as of an upside risk in the NHS at the moment than a downside risk, particularly around additional resources that might come into the system. So we've made some assumption about it in the report about additional resources, and we're pretty certain that they are going to come in, and we're pretty certain that we'll hit the 2 million surplus point. The biggest risk, I think, around the NHS at the moment is that there's additional resources being passed out to CCGs and through into organisations, and we've had to manage that quite carefully, because the national position and really the judgment of success and failure for an organisation financially at this time of the year is to hit what you're actually saying you're going to do, and I think we can say that we'll do that quite confidently, providing that we don't get any further shocks in terms of allocations. But I think we're probably past that point of risk, because there's a lot of nationally people are recognising that and have sort of closed off those income flows. So I think that's probably all I really wanted to say in terms of the position in 21-22, but I'm very happy to take any questions or have any discussion about any of the points in the report.
Thanks, Stuart. Any questions or comments? Nope. So financial plan for next year. I know we got an email out overnight.
Yes, I'm not sure whether people have got that to hand. I think it was going to be incorporated in the papers. That's probably for later publication. So I suppose just to explain where we've been going in terms of the finance, because it is transferring between regions. It's quite an interesting time, really, and quite a complicated process. And I probably need to set it in the context of not, well, probably both systems to understand where things are. The report that you have before you illustrates the sources and applications of funds, and there's quite a bit of detail in there, but there's probably one figure that you need to concentrate on, and that is a figure of financial risk, basically. And there is a balanced position that's detailed in the report that's going before you, but that is built up with at the moment there's a total of £4 million. That is the difference between our current expenditure plans and our income allocation. And what that means is that we're going to have to look at flexibilities in terms of in-year flexibilities next year, look at efficiencies, and look at balance sheet flexibilities that we can manage across the year. So that starts to show, I think that there's an underlying challenge that exceeds that position that we've been experiencing this year, and I suspect in previous years during the emergency financial regime. I haven't been back to fully understand the 1920 position, because a lot of the 1920 position generated the emergency financial regime and has given a sense of where organisations are through that period. So I know in Nottingham and Nottinghamshire that there's been a particular disadvantage about the emergency financial position, and that's led to deficit in year, whereas in South Yorkshire the emergency financial regime has allowed the system to create a surplus position. And so there's in the allocation, some of that has been corrected through transitional arrangements, but it still leaves particular challenges in both systems. I've just been involved thus far in one discussion in South Yorkshire. Although we're technically not part of the South Yorkshire planning system, I did join the finance directors meeting there, which was I think that it's probably fair to say, without sort of publishing all the numbers, there is still in South Yorkshire a very significant challenge emerging through the planning processes, and I think there's some further work required to refine those numbers down to for the submission that's going into the NHS regionally and nationally, and that's due to go in on Thursday of this week. So there was a work programme that came out of the discussions with a couple of hours of conversation with all the providers and the CCG finance directors in South Yorkshire, and that gives a sense of, because the financial health of the providers in South Yorkshire is clearly a key issue in terms of the relationships and the way in which I think we work as a place in the future with South Yorkshire providers. The position in Nottingham and Nottinghamshire is that we are almost certainly going to submit a deficit position into the region. As I say, in the last 2 years, in effect, there's been an underlying deficit due to the way in which the financial regime has been working. So we start in a deficit position, and there's some particular challenges emerging, as you can imagine, at the moment around inflation. For instance, energy inflation alone across the providers, we're estimating could be a cost pressure of 17 to 19 million pounds. It's that material an issue in the system. We've also got expectations about reducing COVID spend, which are particularly challenging. And as we still see COVID rates going pretty much, we can foresee into the first quarter, the planning guidance is assuming that those levels of COVID are likely to be lower, and particularly issues like staff absence. So we will see significant pressures, I think, in COVID in the whole of the system in the first quarter. As a result of submitting a significant and material deficit, I feel sure that I'll have the pleasure of the company of initially the regional finance team and probably the national finance team. But we do understand the reasons behind the numbers and the submissions. We've already put stretched targets in terms of efficiencies, and you know that's where it is really, and it's about being realistic and credible in the figures that we're putting in. So I still, at the moment, am working with Bassetlaw almost as an island in terms of those numbers. And I think the level of financial risk that we've got initially in the plans is probably higher than I thought we'd have. But we do have flexibilities to manage that, and I'm confident that I can recommend that balanced position with risk to the governing body today. Thank you.
Thank you, Stuart. Any questions or comments to Stuart? Victoria.
Just it's a challenging time, isn't it? So just to kind of commend and support that really from Stuart's recommendation. I don't think we're sitting in a position of confidence to say we know all the unknowns. You know, there's lots of unknowns in the system at the moment, aren't there, Stuart? But I think we need to note those risks that have been identified, not least of which the agreement of the contract values. We don't know what is going to happen to inflation over the next few months as well. We don't know the impact of the Ukrainian war, for example, is also going to add a different dimension onto this. So I just think there are lots of risk in the system. We're going to have to be really rigorous in the ongoing review of those risks as we go forward. But Stuart, Bassetlaw will always try and participate in its element of the share of the efficiencies that we need to gain as well. So I think what we need to do is make sure that we've got a really good planning position in place for the efficiencies to be gained over next year. Because I noticed that most of the expectation is that slippage will form part of you know, meeting that balanced expectation, and it slightly worries me. I think we probably are going to need to be a little bit more proactive around managing that than just relying on slippage. So I think just my point really, those risks are really material.
I mean, the reality is that this position has emerged in Bassetlaw since Friday of last week, so we've not had a lot of time to work on it. And it's been reflected very quickly, really, in that efficiencies or the mitigations line. What I will need to do quite quickly, really, is so we have a financial savings group, in effect, as within Nottingham and Nottinghamshire, where we'll look at all of the areas, particularly within the span of control of the CCG, to see what efficiencies we can deliver in there. And so there is normally quite a defined schedule of opportunities with sort of senior responsible officers for each of those areas, and then we'll work up and look and share those efficiencies across the system. So I'm sure you know, you will have had efficiency requirements in the past and will always probably expect to continue to do so. So things like prescribing, CHC, I'd be very disappointed and surprised if any element of the future organisation, so not just Bassetlaw, I'd expect to learn from each other, and we know that there's a continual programme of review of prescribing and CHC and you know and looking at procurement and back office and all sorts of things that will form the sort of package of efficiencies. It is a different programme to the one we would have had historically, which was, I guess, primarily built around demand management and the CCG generating benefit from under PBR of not utilising, you know, not incurring activity-based prices. As I say, it's I think quite a mature system in Nottingham and Nottinghamshire that the providers and the commissioners have been working together for quite a while within the ICS framework, and there was quite a difference in terms of some of the discussions. So we will be looking at the overall cost base of the ICS, but within that overall cost base and sort of transformation opportunities that will look at taking cost out, each individual partner within that ICS will need to look at the areas of span that are specifically within their control, and that's really the figure that we'll be looking for to try and take some recurrent efficiencies out. The programme really just is you know, looking at relatively small levels of sort of a 1% recurring efficiency there and a 1% of slippage and other factors. So it's manageable in the numbers, but the quicker we can look at the overall and get that recurring base sorted out, then the better we'll be. Thanks.
Thanks, Stuart. Idris?
Yeah, I just want to support, you know, sort of some of that. So we knew before the pandemic that the cost pressures within Bassetlaw were significant and increasing. We've now had 2 years of those being hidden, in effect, by the funding regime due to the pandemic. So that has accumulated, I would suggest, sort of even further, because our hands have been somewhat tied in terms of increased efficiencies and so on. So in one respect, whilst very disappointing, not surprising that the cost pressures are greater than they have been previously, because I think this is where we probably would have been had we not had the pandemic. But Stuart's point there, that there will be opportunities to and new things that we can learn in terms of the detail that the wider Nottinghamshire system have already done. And I think we need to sort of follow that through in earnest to make sure that we can share the efficiencies across the entire system. But Stuart's sort of final point there is a really important one for us to recognise, that the old way of getting efficiencies isn't necessarily going to work in the future, and reliance on demand management, when actually we want as much activity to go through as possible. The acute collaboratives are a different nature, and sort of the ICS system bottom line is different. I think quite rightly, we'll ultimately be judged about the bottom line of the entire system in the future. So you can't shift around the cost pressure between commissioners and providers, or between one provider and another. But I think in areas like prescribing, for example, I would hope, sort of there are opportunities there. I think the headline figure that we are at the moment, I would hope and expect to see that in coming weeks come down as we identify, sort of ways of reducing, sort of that headline deficit. But I am pretty sure that we'll be left with a significant challenge after that. And that's something we'll have to work together. And I'm sure both in Q1, while we still retain our statutory status, we'll be focused on that, but also it'll be something we'll be working with our partners right across the system as well.
Thanks, Idris. Any other comments or questions for Stuart? It's always reassuring to actually get back to normal, to sort of seeing hopefully an end towards COVID for at the start of a financial year, or approaching the start of the financial year, for a director of finance to be all doom and gloom. It's good to be back to what I've grown accustomed to.
Pride ourselves on doom and gloom.
So are we happy to approve the draft financial plan?
Thank you.
Duly approved. Thank you, Stuart. And can you thank the other members of the team for getting this out so quickly?
Yeah. Thanks.
Thanks. To the performance and planning part of our agenda, Victoria, welcome back from your leave.
Thanks, Eric. Yes, first day back, so forgive me if I'm not quite on top of these figures as I might ordinarily be. I'm going to take the performance report as read. This is a regular report by now, and people understand the general format of it, but I will pick out some of the more salient points which I think are worthy have just been highlighted. I think the first thing to know is our A&E performance. Obviously, we don't meet the national expectations around A&E 4-hour waits. However, that is a consistent picture nationally, and we're all very understanding and aware of the reasons for that happening. But I do think it is worth noticing that, as we mentioned last month, our daily activity seems to be increasing at a rate which is quite persistent at the moment. So even over the weekend, for example, we saw attendance levels on Monday, so yesterday, of 201, and on Sunday of 163 attendances. So our rolling average at the moment is something like 155 attendances per day, and we know that our A&E department at Bassetlaw is actually originally built for about 100 attendances per day. So that is still continuing to put some pressure on the environment, hopefully, which will be alleviated to some degree by the emergency village reconfig that we've already discussed. But it does demonstrate that an increasing amount of people are using our A&E for seeking clinical support. We have put a range of mitigation in place to support that, not least of which has been the inclusion of now social prescribing support in ED. And that is proving to be quite positive in terms of supporting those wider social determinants of health and impacting on people's overall health and well-being. What we are investigating is how we get the data a little bit more quantitatively validated to understand the impact of that. But I do think it's worth noting that activity does seem to be increasing. We do need to keep an eye on that. In terms of our 18-week waits, obviously, we're not at the 92% target, but we do perform well generally compared to peers. And again, everybody's well conversant around the reasons for that, given our ongoing challenges around COVID and recovery. So you'll see that, excuse me, although we remain below the target and it's 67.3% overall, 66.2% for Bassetlaw patients at DBTH, but in improved position for STH was at 73.8. That compares with our Notts College, which are in the mid to late 60s performance levels as well. As of 1st of March, the CCG still has 254 patients waiting 52 weeks or more at DBTH, and that has been a net increase of 5 patients on the previous week. The vast majority of those, as we've already reported in previous months, still relate to trauma and orthopaedics, MSK, and ophthalmology. We've also got 6 patients waiting for over 104 weeks, and 5 of those, however, do have confirmed to come in dates, and hopefully those are by the end of March, I believe, and 1 is still being followed up. So still some good progress on those very long waits. January's monthly return shows a further 89 patients still waiting 52 weeks or more at other providers, however. So, for example, 34 at STH and some at the Children's Hospital, with lower level numbers at Nottingham and elsewhere. And we've also got about 6 people waiting for those non-DBTH 104-week waiters. Again, we've spoken about them before at University Hospitals of Leicester and Manchester, and we do continue to follow those up and try and work with the providers to get those patients sorted as soon as possible. So there's lots of work been happening within DBTH to try and mitigate that risk and improve performance overall. And as you'll see from the report, that we've actually delivered quite a lot of activity along plan. So we've delivered in terms of day cases, they've delivered 96% of the plan, which equates to about 82% of the previous 1920 baseline activity. And for inpatients, they've delivered 125% of plan, which is about 79% of 1920 activity. Lots of work happening, detailed in the report, to try and maintain that recovery position from DBTH, and indeed with the expectation that we will have resolved all 104 weeks waiters by July 2022. For outpatients, the Trust delivered 94% of new plan and 99% of follow-up on plan. That compares with the 1920 levels of 83% and 82% of activity. So some really good progress being made. Lots of that being achieved by a range of initiatives, including use of independent sector, use of what would be formerly have been called initiative lists or super weekends, as they're now calling them, across a range of different specialties. For example, urology and ENT have got super weekends, and there's a mutual aid plan for ophthalmology in place across the ICS. And as you'll know from previous conversations, we're also doing a lot of work to try and support commuter-based ophthalmology support as well. Ongoing focus from DBTH is obviously those longer waiters, particularly around 40 weeks plus, and those are being aggressively pursued and monitored by the DBTH. In terms of diagnostic waits, again, not where we would ideally like to be, but it is a more positive position that we've reduced the waiting list by about 1,000 patients in September 2021. The reduction is of the magnitude of nearly 4,000 patients at the end of January compared to just over 5,000 at the end of September 21. MRI and non-obs ultrasound are still the 2 tests with the biggest challenges, but also with the biggest move and improvement, with 503 and 888 fewer patients waiting respectively for those. Obviously, that doesn't compare with what the performance was in 1920, but again, the rationale for that has obviously been the impact of COVID and the ongoing impact of COVID. What you will see is the Trust delivered 147% of CT and 127% of MRI activity in January 22 compared with January 21. So a lot of work happening to try and get back to pre-COVID levels of activity, both in terms of 18-week waits and diagnostics. I'm just going to move on. Cancer remains a specialty of focus. Cancer performance has generally been resilient throughout the COVID period, but again, continues to be challenged as a result of COVID. That relates to the one-stop prostate clinic. As you'll see, there is an increased capacity issue as a result of greater conversion for same-day MRI. We've been unable to meet the demand for that, resulting in some 28 and 62-day breaches. There's also been a significant increase in referrals from mid-January onwards, particularly for upper and lower GI and neurology, which is really good in terms of our primary care colleagues identifying patients that do need to be supported through 2-week wait referral processes. But unfortunately, we still need to escalate diagnostics to support and meet that demand. And obviously, we've got increased concern around our wider oncology services provided from Weston Park, and work is happening across the ICS to try and mitigate that risk, with provision being consolidated at the Rotherham site. I'm just going to go on to talk about health checks. Obviously, we've had a lot of focus around health checks, recognising the real importance of reducing health inequalities that this creates. So we at the moment have improved position around SMI health checks. The local position is still reporting has increased to 52%, with still again some variation across the 9 practices, which I know that we are very much engaging with those practices to try and support everybody moving up as fast as possible. But LD health checks continues to perform well. Definitely comparatively, we perform exceptionally well. And at the moment, to achieve the 75% target, we've got to achieve 510 health checks within the remaining period. And if we can achieve 90%, which is what we've previously achieved, we've got to do a few more. So obviously, ongoing conversations with the PCN CDs and with practices individually to try and achieve that really fantastic performance that we used to do. But definitely a good performance, irrespective of that, given everybody's implications around COVID, not least of which, Eric, as you've just mentioned, if we now have a resurgence locally and the impact of that on our local practice staff, that is going to create some challenge on continuing to get over the line with those health checks. I'm going to stop it there, Eric. Those are the main things I wanted to talk through at the moment.
Okay. Thanks for that gallop through, Victoria. Hession?
Just a few questions from myself, really. The first one is in relation to A&E. We know that historically we've had a significant flow of activity from out of area patients contributing to the pressures. Is that still persisting? And if it is, do you know by what proportion of those numbers are coming out of area?
Yeah, it is Hesh. The rule of thumb still remains about a third, up to a third. So it's quite considerable. One of the conversations we're getting into is we're working through the front door model of ED at the moment, which you'll be aware of, working very closely with DBTH to think about what can we do. I've mentioned social prescribing, but we've also been talking about additional capacity at the front door to support triage from a primary care perspective, to support patients to be signposted into self-care and self-management, as well as other surrounding services. We'll need to work much more closely with our other CCG colleagues on that agenda, given the fact that lots of patients are coming from out of area, particularly from Rotherham CCG area. So yes, some work to do on that, Hesh.
Thank you. My next question is around diagnostics. I think the world has changed significantly since the pandemic, and I think that the demand for diagnostics is not going to go away. And I think we started off pre-pandemic talking about a community diagnostic centres, and I wonder whether that we still need to progress with that to the best of our abilities and try and separate out elective diagnostics from non-elective diagnostics and see what proportion could probably sustainably be maintained in the community. I mean, for example, ultrasound, non-obs ultrasound scans, we have locally reduced significant pressures from the MSK perspective, requesting diagnostics, but the majority of the diagnostics are coming from other abdominal ultrasound scans, pelvic ultrasound scans, etc., etc. So I think the historic aspects of diagnostics sitting under the umbrella of a secondary care organisation probably needs to change in the future, where primary care are actively responsible for and accountable for their their diagnostics, with those diagnostics staying within the community is where I see efficiencies coming, because otherwise it's just going to carry on this conversation really. Is there any further progress in terms of the community diagnostic centres or diagnostic treatment centres?
We're obviously progressing with the application for community diagnostics as part of the Mexborough Diagnostic Centre. And obviously that's part of wider considerations across the ICS in South Yorkshire and Bassetlaw around community diagnostics, and there's a second round currently underway, I believe. You're right about where can diagnostics more closely based to where patients live and within a primary care and community setting could be more helpful. I think that some of the challenges around that, Hesh, are around the capital and the funding to support that, and also not least of which is the staff and the revenue associated with that, because we're already struggling with some of this capacity in the system around, you know, the ability of people to read and report on the diagnostics. It's not just doing them, is it? It's about that second tranche of specialist support and ongoing support around it. And again, Hesh, I'm not quite sure where there's further conversations happening from a Nottingham perspective around that, but you're right. I think we need to explore it wherever we can, and we'll continue to do that.
Indeed. I suppose my logic is, when we talked about workforce historically, we've always talked about kind of clinicians having sort of so doctors, nurses, etc. But in terms of diagnosticians, we've always lagged behind in terms of adding them onto the workforce kind of plan for the future. And I wonder whether possibly the R's scheme for primary care could be expanded to potentially take on these kind of dual roles with like we're doing with the mental health practitioners, you know, managed between a secondary care trust and a primary care organisation might be a good way of offering an individual more flexibility and more variety, but still having some sort of accountability in the community. So that was the thought process. Yeah. Sorry.
I think that's right, Hesh. I think there is opportunities. We've already talked about how we come together, don't we, as PCNs even, to think about using our resources collectively in a different way. So, you know, Admiral nurses would be another example of where we've identified that as an opportunity. And I think there's lots more that we can explore around how we use our resources in a more efficient, effective way. And again, that's part of the conversation we're having with our CD leads at the moment, and have got some OD sessions OD sessions planned to work through some of that thinking. So you're absolutely right, Hesh. I think in principle, there's an opportunity here to work differently, and diagnostics would be one area that we can do that.
Perfect. And my final point was around stroke, and I've said this many a times, really.
I know.
I suppose, despite the SNAP data historically showing DBHFT as an organisation overall performs relatively well, Bassetlaw residents still seem to struggle to achieve the performance. And if you look at this performance report, 50% of the delays are with regards to flow within the DBHFT setting. Despite this, we've struggled to progress this, isn't it? And I'm not quite sure what the next step should be in terms of involving DBHFT and actually having probably not a talk about this, but actually putting some actions in place to say, look, the themes are exactly the same. So, for example, ED delay, delaying transfer, CT scan delay, transport delay. You know, 50% are kind of internal flow related matters, and there must be a solution for that.
Yeah, I'm hoping, Hesh, as part of the conversation about the front door model and trying to support effective flow patient, we might mitigate some of that risk potentially, because I do think the timely triage, the timely signposting the patients into appropriate care and management will help. I think also the development of the SDEC routes for other areas, you know, medicine and for surgery, would probably help as well, because hopefully patients will be identified early and be able to be fast-tracked into appropriate diagnostics. So I'm hoping those will make a difference to those activity levels, Hesh. You're right, it's a perennial problem that we've had. And we've tried, haven't we? We've had the stroke consultants come and have that conversation with us about what else could we do, and that's always another option to us. But I'm hoping those other pathway redesign issues will help some of this over time.
And I think that's always been the challenge. When the consultants come, they talk with a DBHFT hat on or an organizational hat on, and I think we need to progress that to a place-based discussion. So we actually talk about that place as opposed to DBHT organization, and I think that's where we've always struggled. Thank you. Sorry, I've taken lots of your time.
Oh no, not at all, Hesh.
Thanks, Hesh. Kumar.
Hi, thank you. Heshen has actually stolen my agenda now. And I just wanted to focus then, for taking the next step. Transport delay from Bassetlaw Hospital is clearly a transport with EMAS or ambulance, I think. So I just wondered whether, we have got a clear break, but a transport delay from Bassetlaw Hospital is a clear inequality. And that really, it's not right for Bassetlaw residents. So I just wanted perhaps that one element we take it further from today and explore, because the number of people we transfer from Bassetlaw is going to be less when compared to, and of that 3 is quite substantial really. So it's not a fair play for our residents. So if we could take, thank you.
Thanks, Kumar, for that. Any other questions or points for Victoria? Nope. Thank you. Planning, Victoria.
So we just wanted to give governing body an update, a general update, Eric, around the planning process and our engagement in it at the moment. So I'm going to talk around the subject rather than directly to the paper, which was produced at a point in time. If that's okay, and then the risks will come out of that conversation as well, which we highlighted earlier as part of the agenda. So colleagues will be aware that when we first started thinking about this planning round, we were part of the and fully embedded still within the South Yorkshire and Bassetlaw ICS planning process. And then obviously with the boundary changes, we were then going to be supporting Nottinghamshire system as well. We were then asked to basically look both ends, both north and into south, and participate in the planning rounds, which is quite appropriate given our future in the Nottingham and Nottinghamshire ICS. Then further development happened in that we were then clearly indicated that we will move only into the Nottinghamshire ICS for the planning round and not into the South Yorkshire ICS for the planning round, although we continue to engage in meetings and be part of the conversation. So there's been a lot of to and fro-ing around where Bassetlaw sits in planning rounds. Irrespective of all that, we've continued to engage actively wherever we can to support conversations both into both ICSs. As a result of that, we had one planning conversation with our DBTH colleagues and Doncaster CCG colleagues with respect to the development of the planning activity levels for Doncaster and Bassetlaw hospitals, which was very positive in the sense that there is an expectation that the national expectations will be met for the current elective care recovery. So DBTH have given assurance that they are on track to reduce the PTL size, reduce the number of patients waiting 104 weeks, as I've said, eradication by July, and also to improve cancer performance by March 2022 for this planning year. And obviously that will allow us to move on a positive footing for full elective recovery, definitely into the first 6 months of next year, and avoid the impact of the winter pressures that we've had. They are aiming to achieve 110% elective activity expectations for 22-23, and funding is made available to support that through ERF funds. And obviously the challenges are different in different specialties, as we've already mentioned. Ophthalmology and trauma, orthopedics are the ones that are most challenged, will continue to be so. But as again, I've already indicated, lots of insourcing, outsourcing opportunities to try and mitigate that risk. In terms of the planning expectation itself, just some highlights really, just to demonstrate the challenge that this is going to create for all health systems, health and care systems. There are 10 overall priority areas that we've been asked to support in our planning assumptions. One, a continuation of investing in our workforce, so increase the training and recruitment offer to make sure that we've got the workforce capacity there to do the recovery. Respond to COVID-19, and obviously, as we've already heard in our previous conversations, that continues to be a challenge for us. But that also therefore means we need to continue to put exceeding amount of effort into supporting booster campaigns, vaccination campaigns generally, and supporting our patients, our staff to be vaccinated, and to obviously review ongoing treatment options for long COVID, etc. Recovery of the elective care performance is obviously pretty critical, not least of which is in our cancer performance. So the expectation of a continued restoration of fully operational cancer services in the increasing diagnostic capacity to 120% of 1920 levels, reducing or eradicating those long waits, as I've indicated, and increasing more initiatives to reduce outpatients and increase patient-initiated follow-ups as well. Increase pre-pandemic levels of elective care by 10%, which is no mean feat, but it's our expectation that we should be able to achieve that. We've also been asked to improve our responsiveness around urgent and emergency care. So that includes the development of more virtual wards. So 5,000 beds are expected to be created through that virtual ward experience for our patients, eliminating 12-hour waits, and plan for delivering anticipatory care. So that preemptive optimization of patient care and well-being. And also to grow our 2-hour urgent community response services, which we are doing in Bassetlaw, to make sure that we've got that 8 to 8 service 7 days a week. And that's going to be provided in Bassetlaw by our Notts Healthcare colleagues. We've also been asked as part of these 10 priority areas to grow and improve mental health services, and that includes those for learning disabilities and for autism services, to improve provision of crisis services, for example, and to have a robust mental health workforce plan to accompany that, and also to expand provision of services for children and young people. Obviously, we've got to still make the most effective use of our resources, and that will be in our locally held contracts, as well as obviously supporting wider ICS contract development, as Stuart's already highlighted, working closely with our acute colleagues, particularly now into Nottinghamshire. Another area of the 10 priority areas is around digital development, improving access to records for patients, improving care digitisation, and system planning around digital development, digital maturity. Another key area that you'll be aware of is the development of population health and reducing of health inequalities. And as you'll be aware, we've already made significant inroads in this in Bassetlaw already, with significant investment in our community and voluntary sector to support this agenda. But it also includes expectations around prevention, flu and COVID vaccinations, reducing antibiotic use in primary secondary care, and restore diagnosis and management of the 6 main conditions causing most of the elective activity. And another key area of the 10 priority areas is improving access to primary care. And obviously that means supporting our PCNs to develop their maturity, increasing the number of GP and PCN roles through the R schemes, and also increasing our GP appointments, both virtual and face-to-face. And then the other area that I've left out, I think, is around the establishing of the ICBs, which obviously is another national priority area, which you will also be aware that we are working very closely with our Nottinghamshire colleagues to support our maturity into that system by July. So lots and lots of opportunity for Bassetlaw to continue to perform well and do its best for our local patients and improving patient outcomes. But there's going to be significant pressure, as already indicated by Stuart, on our resources, our financial and our workforce resources to deliver what is a very, very ambitious agenda, a national ambitious agenda, as well as meeting all the priorities from the ICS and our local place-based priorities as well. So I don't think that those challenges should be underestimated. So in terms of risk and mitigation, all those areas present both opportunity for us to do better, but also risk in terms of managing those those workforce and resource constraints, I think, that will be increasingly emerging over the next financial year. I'll leave it there, Eric, in case there are any further questions.
Thank you, Victoria. Any questions? It was so comprehensive. You've stunned us all, Victoria. Thank you as ever. And the risk update was already included. So we're moving on to transition, Idris.
Yeah, thanks, Eric. So we touched on some of these points. I'll try not to repeat too much, but I'm pleased to say that the establishment of the ICB board has developed, so quite significantly. And I think from a Nottingham and Nottinghamshire perspective, with a high degree of continuity, which means that with Stuart's appointment to the ICB board and Lucy Dadgers as the Director of Integration, obviously she's currently the Chief Commissioning Officer, and Rosa as well as the Chief Nurse, means that they're already in post for the rest of Nottingham and Nottinghamshire. So that does allow for quite a smooth transition in terms of that executive team. The medical director will be appointed shortly as well, so then we'll have a full complement. Just for completeness, in South Yorkshire, they've also appointed their executive team for the ICB designate. So Lee Uthwaite, from a Director of Finance point of view, he's currently Chesterfield Royal Director of Finance, and Kathy Winfield, who's the Chief Nurse currently at the University Hospitals of Derby and Burton, has been appointed as their Chief Nurse. And David Crichton has been appointed as their Medical Director, and of course he's currently the GP Chair of Doncaster CCG. And Will Cleary-Gray is going to be the Director of Strategy and Partnerships, and Christine Joy, the People and OD lead, and obviously Christine's already involved in the South Yorkshire system. So I suppose the difference between the two systems is their Director of Finance and Chief Nurse are not yet in post, whereas the Nottinghamshire system has the benefit of them being in post. These are all people we've been working with for quite some time now in terms of managing that transition, in looking at what the Bassett Law Place will be structured like and what the relationship will be with system and place. So we could work in earnest now in getting the fine detail of that agreed. And that should be agreed well in advance of the sort of the formal transition into the Integrated Care Board at the end of June, notwithstanding risks in any delay of legislation and so on. It means as well that for a lot of the shared services that we've got with South Yorkshire, and Victoria's been leading on this, that we've got a clear plan about which shared services. These are largely what some people might call back office, like HR and procurement, information governance and so on. But it also includes very important, some issues, not that they aren't, but like IT, for example, including GPIT. So for all of those, we've got a proposed final draft plan that's just going through agreement with the various parties that will describe which services still transfer on the 1st of April, and a number of them can and will, which will transfer on the 1st of July into the new arrangements, and there's some of those, and which actually we're going to sustain for a longer period. And the longer period ones, for example, GPIT, will ensure that we've got maximum continuity and no disruption. And obviously with the establishment of the ICB, it's no mean feat to get this over the line smoothly and without any sort of bumps. So protecting some critical areas, particularly those supporting direct patient care, it's seen, I think, as a very pragmatic and sensible move, which we support. So we'll continue, like I say, to get into the detail, and I hope that in Q1 we'll be able to describe that, so a bit in more detail for governing body. But in short, I think the transition is going to plan, notwithstanding moving goalposts of timescales, and we don't envisage, and we haven't identified any new or significant risks, and we're implementing it as a smooth transition rather than a cliff edge, sort of on the 1st of July. Much of the arrangements will be in place, sort of before then. Victoria may have something to add, both in terms of the transition, because she's the SRO for this, but also perhaps on the place-based arrangements. And I know they had a really good meeting sort of within the last few weeks that had quite a comprehensive agenda and good representation at a place level. So I don't know, Victoria, if there's anything you did want to add.
Just in terms of shared services, I think that's right, Idris. We are progressing those quite well. I think the one that we've got to maintain our eye on very closely is around the digital and IT, to make sure there's absolutely no disruption whatsoever to patient care and continuity of services for our practice. So that's been a big priority, and it's why we are taking our time to make sure that we're absolutely going to support a smooth transition of those arrangements. So I think that's giving confidence to that process. All the other areas are services that we are already working closely with other CCGs to deliver. So in effect, we're just working with another CCG to closely deliver, and indeed another ICS to closely deliver. So I think the risk around that is minimal. Obviously, some of those areas that will impact on people, particularly our workforce more directly, is related to HR. And we'll be doing some further comms engagement more directly with our workforce very shortly to make sure that our workforce are aware of those changes, which in effect will be minimal to them, but we'll need to make sure that they're aware of them. In terms of the place-based partnership, you're right, we had a really good conversation at the last meeting, particularly around our reducing health inequalities agenda. We talked very much about our mental health and the very vast range of investment that we're doing around supporting reduced health inequalities related to mental health. As we know, that's one of our priorities as a place. Next month, we're going to be doing a lot more around homelessness and how we're supporting homelessness as well across our partnership. What we did find, Idris, is that we had so much to talk about, in fact, that we've decided to extend future meetings because we didn't have enough time to go through the range of conversations that we would find helpful. Key areas of work I think that we are going to have to focus on in future are around the development of our governance arrangements and our model, obviously further to the development of the integration white paper. It clearly indicates that there is an expectation that we've got governance arrangements in place by April of next year, which are going to clearly articulate our ability to reconcile our differences if they do arise, and where they do arise, that we've got a really good, robust governance and oversight. We're also going to be having to make sure that we continue to mature our oversight of our own performance as a place. And for that, we're working very closely with, again, our NOTS colleagues to develop a dashboard for performance for the partnership to oversee. And that will be a general one, as well as another dashboard that will be specifically related to our health inequalities work as well. So lots of work ongoing, Idris, but I still think it's very much a work in progress and very much targeted towards delivery of a fully operational place-based arrangement alongside our other places in Nottinghamshire by April of next year.
I think it's worth sort of just noting or repeating that from a Bassetlaw Place leadership perspective, Victoria will be the place director and Eric the clinical lead, and we've identified all of the leadership team with one exception, which is the deputy clinical lead, which is just being sort of followed through now. That does put us in a really strong position, and we compare ourselves with other systems and places, and the developments and the position we've got to is somewhat ahead of many others. And one of the reasons I say that is that I think we need to maximise the use of that, because it does make both for a smooth transition, but probably most importantly, Victoria's just mentioned spending more time at place discussing the breadth of issues, that it gives us an opportunity to get sort of into those topics about planning and delivering for the future, because what we're here for and always have been is the reduction of health inequalities and supporting the best quality services in Bassetlaw. And we've spent 2 years working in great partnership, but in response largely to a pandemic. Whereas now we need to extend that great partnership. And like I said, most of those key leadership arrangements are in place on a designated basis already. So we can really work on that long-term goal of reducing health inequalities, which I think is a very positive position to be in.
Stuart, do you want to come in?
Yeah, I suppose just to comment on that. I mean, there's a huge amount of establishment work in terms of transactional things and submissions and assurance, and huge amount of evidence that needs to be produced and everything else. And we've got colleagues working on that, and it's quite arduous to be fair. But whilst it's clearly important in terms of the establishment and authorisation of the organisation, the important things are the things that you've started to talk about there, about how we can I'd probably go back to concentrating on delivering sort of transformational change that will deliver new and improved services for local citizens, and try and move the agenda towards prevention and improving the outcomes. So I think we can't underestimate the transactional bit of establishing the thing, but one of the beauties of place really is that you should be shielded to some sense from some of that stuff. So I have to sit through the delightful regulatory meetings with colleagues that are doing all that stuff, but I do think that at place level that we can crack on with that. But I suppose the other thing that I just wanted to say is that if the ICB is going to be successful, it does need to, I think, launch as a new organisation rather than as a replacement CCG across the system. And I think that's a debate that the ICB probably hasn't really had yet about what that looks like. And when all the appointments are made and the unitary boards together and linking in with place, hopefully it's a really refreshing new stance that we'll need to take. And you might even find a finance director with a smile on his face eventually as well, Eric, if we'll work on that. But yeah, so it's it should be seen as a new start, and we should be enthusiastic about that and take our staff with us. So thank you.
Definitely, thank you, Stuart, for that. All right, audit committee update, but no one down for this. Sue isn't here. Anything you want to highlight, Sam?
Thanks, Eric. I think in terms of this update and primary care commissioning, it's the same flavour that's been discussed in terms of transitioning, the arrangement. So on audit, there was an auditing comment that Sue chaired as well prior to our audit committee, which gave assurance that transition is progressing well, finance is working well together. Significant assurance was brought on the data security standards, similarly at place. So we then had the Bassett Law meeting. I think again we looked at transition arrangements. Victoria came to the meeting and was scrutinised on her risks, which some of them will be on the agenda today. And I think you can note that there's quite a few risks for archiving later on. So in terms of that's the audit update. I can take primary care as well if you want, Eric.
Please, Sam, if you would.
Yeah. I think on that one again, we've got assurance around the primary care transition operational group that Andrew and myself are linked into. Andrew also is embedded, as Victoria said, in a lot of the other Nottingham and Nottinghamshire transition arrangement meetings. Again, there's some sessions on the draft primary care strategy that we've been asked to participate in. One of the sessions that I'm attending is tomorrow. I think we've added a couple more primary care committee meetings in to taking us up to the transition. And just to add on, a personal thanks and a thanks on behalf of Primary Care Commissioning Committee to Heshan for always bringing his attention to detail and his wisdom. And I think for overall just being, a real asset to Bassett Law and really passionate about bringing the best care for the people, and also being a really nice person to work with, Heshan, a true people person. So thank you.
Thank you, Sam. We'll all second that in terms of people person to actually work with. My only slight worry about the primary care committee going forward is Corsi, because currently Heston and I are on it as clinicians, and one of us needs to be there. With Heston leaving, just need to double check the dates just to make sure I can be there. Unless Nicola, you count as a clinician as well, don't you? Silly me.
Yeah, I was going. Yeah, I do struggle though to attend sometimes because it does clash with the Cancer Alliance, and I represent the chief nurses there. So, we perhaps just need a quick conversation beforehand.
Fantastic, Victoria.
Yeah, I think Quarry C is probably PCC Quarry C is probably the ones I'm least worried about, Eric. I think it's quite open, if I remember correctly. That I think it's Sam or Sue and one other exec. It's a relatively loose Quarry C requirement. We can look at it again to make sure, but I think we should be okay.
Thanks, Victoria. There's no other points. Corporate, Idris, you've got a number of papers here.
Yeah, I'll take them in turn, but sort of do a general introduction because they all, I think, sort of link together. But the first thing I wanted to note was that the author of these is Cheryl Rollinson, and we've been talking about how much Heston has sort of contributed to the success of the CCG, and I just wanted to call out Cheryl's role in this. Cheryl started with the CCG just after I did, and has been here throughout, despite actually obtaining another job some time ago in Doncaster, but continuing to support the CCG in all the corporate governance. And she has been absolutely outstanding. And I know this is a bit of the boring bit about governance and the committees and things like that, but it is a building block, a foundation of a successful organisation. And it's about our transparency. It's about how it's working, sort of in an open and an effective way. And you only have to look back at the audit reports of just about every element of the work we do and how we go about it from a CCG to recognise that it's been one of the best audit sort of result programmes over years since Cheryl has actually started. And there was a lot to do, to be honest, in terms of establishing this good governance. This isn't just something that comes out of thin air. She really did establish this, and she's really made her mark, I think, in terms of good governance. And one of the best audit programme successes that I've seen in any organisation that I've worked in for 32 years. So it is really exemplary, and we owe a gratitude, I think, to Cheryl in delivering that. And of course, with the new shared arrangements and things, corporate governance is something that is transferring sooner rather than later, although Cheryl will continue to help us with some IG work in terms of the toolkit submission and completing the annual reports for us. So we're holding on to it just a little bit longer for some things, but fundamentally our governance arrangements will start to change now. So in terms of the first item, corporate governance for Q1, a lot of this is about, well, how do we handle Q1? And we want as much continuity as possible. So we're not making any changes to our constitution. We're continuing with all of the subcommittees, recognising that some of those subcommittees may meet in common with our Nottinghamshire colleagues. And indeed, there may be meetings that aren't required, and we're not going to have meetings for meetings' sake. And I know particularly when we get to the final month in June, some of those may be a couple of months before the CCG actually closes. So I think their focus will need to be on the smooth transition and closing down, sort of governance issues from a CCG perspective. But we're keeping them in the diary, and we've got that timetable that's clearly set out sort of in the paper. So all of the governance arrangements, I think, is set out. Where there are terms of references to be reviewed or policies and things like that to be reviewed, we're being very pragmatic and fundamentally suggesting that those are rolled over wherever possible as is, so take us through Q1. So we're not causing ourselves more work than we need. We're continuing with the good work, the good structures, and the very effective subcommittees that we have to governing body throughout sort of Q1. So that's the fundamental, I think, the recommendation there, Eric.
Makes a lot of sense, Idris. Everyone's happy? Yep. So if I go on to governing body assurance framework,
So there are 17 risks, one very high, which is the ophthalmology sort of issue for follow-ups that we've discussed previously. As you know, that is being overseen by other committees, and there is an action plan in place that hopefully is starting to reduce that risk, but at the current point it remains sort of high. We've got sort of 3 new risks identified, but also 10 risks and 3 governing body assurance framework risks that we're proposing are archived. Obviously, all of these have been through the relevant subcommittees, and the archival, is that a word? Archiving the 10 risks and 3 governing bodies is largely to bring them up to date. Some of those are a bit historic now, so referring to the European Union exit, remember that, and others because it's near year end and we're far clearer now about what the risks are, where they impact on this financial year, and some of them are rolled into identifying new, more generic sort of risks. So I think you're probably, for each of the areas where you're cited, will have already seen these going through the various subcommittees. So it's just recommended that we accept the current position and we confirm that these assurances do mitigate the risks and that they're being appropriately handled. But happy to try and answer any questions or to pass them off to other people who might be better positioned to answer them if they're specific.
Thanks. Any questions or comments there before we decide whether to approve or not? No, which is testimony to the great processes we have in place. Are we happy to approve the recommendations? Duly approved.
Okay, so the subcommittee annual reports, there are 5 of these that are described. So for the committees for audit, remuneration, primary care, quality and patient safety, and the exec committee. And I think these reports demonstrate the continued effectiveness of each of those subcommittees. And we're just seeking ratification of that by governing body.
Sam?
Thanks. Just on the primary care commissioning one, there is an updated one because there was a meeting on the 4th and members wanted a section adding in on transition, and also there was just a few other things that needed correcting. Andrew's completed that, so we can circulate that to members.
Thanks, Sam.
Thanks, Sam. Are we happy to ratify based on the fact that there'll be a updated primary care committee report? Duly ratified. COVID and flu, Idris.
Thanks, Eric. So we currently have 9 inpatients in Bassetlaw with COVID. That's up 4 from last week, but it's a handful of numbers. So I wouldn't put too much, sort of weight behind the fact that it has increased. It's a bit early to say. Although there are other parts of the country who are starting to see some increase in acute admissions due to COVID, although touch wood, very few requiring ventilation or critical care. There are various views around this. I would point to the fact that some of the older and most vulnerable are due for their next booster that will be started within the coming weeks, so their protection sort of may be reduced. Also, you can get Omicron more than once, and that just being endemic in society, I think is something we may see for quite some time. The rates of COVID per 100,000 are still high. They're nowhere near the Omicron peak, which was unbelievably high, but typically between 200 or 300 per 100,000. I think there is a bit of a health warning on that, as well as testing, and because of the relaxation of restrictions, it is more difficult to say whether that is directly comparable to when we had great amounts of testing. And I think in future we're going to rely more on the ONS survey. So some of you may even have received a letter from the Department of Health and the ONS and Ipsos Mori about being involved in that, and I think that will give us sort of the most accurate picture going forward in terms of the rates of Omicron in society. But like I say, I think what we're now seeing is is Omicron in particular just circulating within society. There has been news reports and discussion about the Omicron variant BA2 and the Delta combined Omicron variant. As far as I'm aware at this point, there's no identified increased risk, although the rates of transmission, how infectious they are, may be increased, but we're not seeing, touch wood, any increase in severity of illness. And certainly for those that are fully vaccinated, including their relevant boosters, the protection against severe illness seems to still be extremely effective, which is what is supporting us returning to a bit more like normality in terms of the restrictions, without the effectiveness and the spread of the widespread use of the vaccine. I think the situation would be very different. And I'd suggest you only need to look at Hong Kong, for example, and one or two other parts of the world that are really struggling with acute illness. So I think that's evidence enough. Flu levels still remain very, very low, quite significantly below the previous year's average. And if you combine COVID and flu, then the rates of admissions and certainly the number of deaths at this point are significantly below the seasonal average. So in terms of people having a degree of confidence to support the reduction in the restrictions, when you look at the worst impact of winter flu compared with COVID and sort of combined, it is less than previous years on average. That doesn't mean to say that we shouldn't continue to take precautions, and actually some of the precautions that we are currently taking is what is reducing that and the transmission of flu. And I wish people had done it before. In terms of when we have a bad flu season, we see very high numbers of avoidable deaths. And so simple measures of a bit of social distancing, actually when you are ill, not start continuing to mix with people and going into work, the use of hand sanitizer and things are all extremely effective in keeping the rates of flu down as well as COVID. We have 4 outbreaks in care settings at the moment, which is relatively low, and again quite low acuity as a result of those outbreaks. So that is still a positive picture. The 250,000, because I'll get the figure right now, so won't boost us up too far. 250,000 of the doses delivered now takes us to nearly 87% of the population having had their booster, not just the original, but their booster, which is sort of excellent to see. Staff absence has also reduced. It's still there, sort of a bit like a winter flu season or where there's background illness, but it is more at the levels that we saw before the Omicron wave. And as you know, the Omicron wave's biggest impact on the delivery of health and social care was the number of staff that were off sick and isolating. That was probably the single biggest problem that we had during the peak of that Omicron wave, as opposed to the severity of the illness. It was our ability to continue to deliver those levels of service. So it's really good to see the sickness and absence levels have significantly reduced. So I was going to say cautiously reduce restrictions. Not sure it was entirely sort of cautious, but it does seem to be sort of quite successful, and with just maintaining a degree of protection, particularly for those most vulnerable, and that includes in healthcare settings the continuation of wearing masks and so on. Then hopefully we'll continue with this sort of new level of COVID in society, but with relatively low severe impacts on individuals. This does help us start to meet again in person more, and that includes returning to the offices. And from a CCG point of view, quite a lot of work has been done about managing that safe transition to a hybrid model of working from home, but also coming in to the offices and working face-to-face part-time as well. And over the coming weeks, I think we'll see us transition to that new way of working. Happy to answer any questions, Eric.
Thanks, Idris. Any questions or comments for Idris? No. Well, thank you for that update. I've still to see a case of flu this year. Didn't see any last year, and hopefully I won't see any. Any other business? I haven't been informed of anything. Nope. Well, shall we bring the public committee to an end? We meet again on the 17th of May. We'll have our developmental session in April as planned. So we can stop recording, Mel, and make it 11 minutes past. Shall we come back for 25 past?